Good evening, everyone, and thank you again for making the time to join us tonight. If you are part of our Interprofessional Hot Topic series in January and February, you'd know sort of our regular routine and why we've established this series. We had big plans for March, April, and May, and more interesting topics then, but unfortunately they got interrupted. However, I'm so very pleased that we're establishing the series again, and that we have a fantastic team tonight to share their expertise and their knowledge, but also how they work together well as a team. So just as a side, we have students from all our three schools tonight who have registered, from our School of Rehab, from our School of Medicine, and from our School of Nursing. And I know they were all looking forward to tonight. Our presenters have a presentation, but I know that they have left some time, and there will be room for Q&A. So if you think of questions along the way, please feel free to put them in the chat. And myself and Nikole will keep an eye on the chat, and then we'll take those questions up when there is time during the presentations, or if not, we'll take them up at the very end as part of the Q&A. And I always forget to introduce myself, but I'm Claudiana. I work in the Office of Professional Development and Education Scholarship as Director of Education Development, which includes faculty development and interprofessional education. I won't take any more time and space because I know we have our fabulous team for tonight, and I'll let them introduce themselves. I know you've all received their bios, so you know a little bit of who is who, but they can do a fulsome introduction in a minute. And the topic tonight is the interprofessional team-based care of the critically ill patient. So it is something that is certainly timely and relevant to all of us. So thank you again. We're very grateful that you're here with us tonight, and all yours.
All right. Well, thanks again, guys, for asking us to be part of this. It's quite exciting, and hopefully we'll be able to share some really helpful information with you and get lots of great questions as well. So I'm Cathy MacGillivary. I'm the social worker in the intensive care unit. I've been here for 12 years, worked with a great team, and I will continue to let you go down the list just so that you have on your screen who else is going to be talking as part of our team tonight. Nikole, perhaps you could speak next. Introduce yourself. Oh, we've got a bit of extra feed there. Nikole, are you with us? Oh, maybe she's just having some troubles at the moment. How about Megan and Brianna, two of our amazing pharmacists in the intensive care unit at Kingston Health Sciences Center? If you can introduce yourselves.
Hi, so my name is Megan. I'm a pharmacist here at Kingston General Hospital and most recently pharmacy manager for clinical practice. But I do maintain my clinical practice mostly in the critical care in the ICU area. I did my residency here in 2012 and have been practicing ever since.
And my name is Brianna. I'm also a pharmacist here in the ICU. I finished my residency this past summer, and I've been working in the ICU ever since. So that's been for about 6 months now.
Great. Nikole, do we have you there yet to be able to introduce yourself?
Now try. Okay, I'll try again. Can you hear me now?
Oh, it's better. Yes, go ahead.
Okay, good. So I'm the RN here today. My name is Nikole. So I became a nurse in January of 2018. I first worked on a medicine surgical floor And then I moved to critical care in Kid 2 ICU just over a year ago. It's a bit of a nursing history.
Great. Derry? Do we have Derry with us already? Derry Thibeault?
There we go.
There we go.
Hi, good evening, everybody. My name is Derry Thibeault. I'm the charge respiratory therapist at KGH. I've been RT for 20 some odd years. All of those years, I've been in critical care in one capacity or another. The last 8 years, I've been in this charge position, generally coordinating and acting as a resource.
Great. Al?
Thanks, Cathy.
Ooh.
Is that better?
Yeah, we've got a bit of feedback there, Al.
Al, I think you might still have your other connection live, and that's giving you the feedback.
Is that better?
There's still some feedback there. I don't know if you have
Okay.
someone else in the room with you or not, but
Oh,
all right. Let's see if third time's a charm.
It might be if he's in the same office as Brianna.
It
No?
could-
Okay.
no. As you guys can tell in the audience, of course, these days with Zoom, and you never quite know how things are going to run. So thanks for your patience.
Cathy, it's Suzanne. While we're waiting for Al, do you want to put these slides in presentation mode? It'll make them a little bit clearer for us.
Yeah, I can do that. Like this. Is that better? All
Hi.
right. Okay. Al, I don't know if you got your media worked out there yet. Maybe while he's doing that, we can go move on to Kimberly, to Kim Gough, our dietitian.
Yeah. Hi, everybody. I'm Kim. I'm a dietitian at the ICU, and I've been working at KHSC since, or been a dietitian since 2004, and most of that time has been at KHSC, and probably the last 5 years or so have been in the ICU.
Great. Al, do we have you yet? Oh, no. Everybody loves Al. We got to hear from him. Well, in the meantime, maybe Suzanne, you can introduce yourself, and then we'll go try one more time for Al.
Sure. My name's Suzanne Bridge. I'm one of the intensivists here in Kingston. I've been working in the ICU since I finished training in 2011, and I moved to Kingston in 2014. So I've been here since then.
Great. And Al, do we have you yet? I guess
Cathy, I don't see him. We'll keep an eye in the waiting room.
Okay.
Case. Yeah.
All right. Well, that's okay. He's a fantastic guy. So if we can get him in at any time, that would be great. So folks, the other thing to know is that although we are the people that are here talking with you today, we are but a small representation of the team in the intensive care unit. Just as the slide says, the team is so much larger. We have personal support workers, occupational therapists, speech language pathologists. We have Trillium Gift of Life coordinators, research coordinators. We've got a huge administrative and leadership team who basically keep us afloat as well and keep the natural order in the ICU. And we're really fortunate about that. So just to give you a sense that we are a representation of that, but it certainly takes a much larger team to get through the day every day in ICU and critical care. I think that Al's been able to join us, so maybe before we move on, we'll get a chance to let him introduce himself.
Thank you so much. Can you hear me okay?
Perfect, Al.
Thank you, and my greatest apologies. My name is Al MacVicar. I've been a physiotherapist for 25 years. I've been here in the ICU for the probably last 8 to 9 years, and really looking forward to joining you in tonight's presentation. And again, sorry about that snafu. Back to you, Cathy.
No problem, Al. I suspect you wanted to just get a little bit of physiotherapy activity into that whole into the whole presentation. You had to make huff it down to another room. So glad that you could join us.
Thank you.
So guys, just so that you know, most of the time when people think of the intensive care unit and they think about rounding or going on rounds to review patients, they actually think of this picture where they have a team that stands there together talking, but it's actually a lot more complicated than that. It's really more of a dance. Sometimes it can be chaos. Other times we can work really close. We can work hand in hand. But surprisingly enough, at the end of the day, despite all the people and all of the activities and all of the crises and unexpected things that happen in a day in ICU, it really turns out to be quite a harmonious activity. And so hopefully we can shed a little bit of light on that for you today. First of all, just to know what we're going to be able to get out of the evening. So we obviously introduced everybody from the team that's able to be here tonight with the intention of giving you a little bit of a glimpse into the day in the life of each of the disciplines that are here tonight that work in the intensive care unit at KHSC. A little bit about what each of our individual roles and responsibilities are. And then we want to focus on some moments where our collaboration really comes together. Things like interdisciplinary rounds, morning rounds, case conferences, and resuscitations. And we'll elaborate a little bit on that as we get there. And then we're going to go through a case presentation and certainly look for a bit of interaction and feedback and thoughts from your groups to see what your thoughts are, maybe taking it from the perspectives, our perspectives as well, and questions and answers at the end. So first, I'll turn it over to Nikole so she can share with you her discipline of nursing within our larger team in critical care.
Absolutely. Hi, can everybody hear me okay? I just want to make sure it's working this time.
Yeah, it's great.
Okay, good. Before I launch into. So a day in the life of a nurse in the ICU. So I'll give for an example a day shift because I feel like that's more eventful. So we're with the patient usually 1-to-1 or 1-to-2. We're with them for 12 hours, so we do 12-hour shifts. So typically what my day looks like, I come in, receive report, I review the chart, look at labs. I sort of just look at the patient, get their general status, and identify if there's anything critical and needs like immediate attention from the doctor, and then I would call them obviously if they're needed. Then I would go in and complete my head-to-toe assessment, look for any changes or concerns. In the meantime, I'm monitoring vital signs, I'm giving medications, titrating medications to specific, blood pressure goals, giving, blood products, other medications that they may need, like antibiotics. And we're also, and this is in close coordination with the RT, managing the vent. So the nurse will sort of manage basic ventilator stuff, like if they need a suction or like if they're desaturating really quickly, we can beg. But then if they are deteriorating, we'll call the RT quickly. So we work really closely with them and we assess daily if the patient's a candidate to be extubated. So the RT will check for certain things that we look for to see if they can be extubated. Then after that, we probably would do our morning rounds, which I know we're going to get into a little bit more detail there. So that's when I would present my head-to-toe assessment and then bring up any issues that I had concerns about that weren't immediately pressing. And that's usually with, at least in our ICU, it's usually with the attending, the fellow residents and pharmacy as well can sometimes be there. And then we, implement the orders from rounds, and this can often be pretty extensive. Like we might extubate the patient, we might need to go for imaging, so we have to coordinate with RT to do some transportation. Might need to assist with procedures. For example, if we extubate a patient and they don't do well, we might have to re-intubate. And then we might, we'll also provide personal care, so like bathing and that sort of thing, and we work closely with the PCAs as well. And what else? We are also always in contact with family members, so if a family member calls in, we provide them updates. If they would like to speak to a doctor, we coordinate with the doctor and sort of let them know the family would like an update, or if we have concerns, then we work with social work to sort of work out those concerns. We'll participate in family meetings as well. and discussing goals of care. We'll coordinate with PT and OT if they come by, so to do range of motion activities or dangle at the bedside. We'll also work, and I think the biggest collaboration is with other nurses. So we're constantly collaborating with other nurses beside us, whether it's for, break coveraging, managing more than one entered patient to cover each other's break, or even just sort of bouncing ideas off of each other. Nurses and everyone works really, really closely in the ICU. I'll also sometimes have a student or an orientee with me, so we're constantly teaching. Some nurses also have additional training, so they can manage CRRT, which is continuous renal replacement therapy, balloon pumps. Some nurses are trained to insert PICC lines. So there's lots of extra certifications there as well. There's even nurses too who work specifically in wound care. So if you have a concerning wound, you can consult them. And then also just dealing with any sort of emergent situations, for example, like code. And that's just when we really work as an interdisciplinary team there as well. Any admissions as well. We've really worked together there to just ensure that all the orders are completed. And especially too, because we're a teaching hospital and sometimes there's new residents and that sort of thing. Working with them as well to make sure all the orders are there, identifying things that might have been missed, and that sort of thing. So I think that's pretty much it. And I think that covers everyone that's here today. So nurses work with everyone. Good job. It's really, really great.
Thanks, Nikole. That's great. All right, Megan and Brianna, I'm going to pass it over to you guys.
Thanks, Cathy. So I'll start with the general role of the pharmacist, and then Brianna can walk you through a typical day in her life. So as a pharmacist, our main role is to optimize drug therapy and identify and resolve drug therapy problems. Some of the unique things we wanted to highlight that are particularly relevant in ICU or a critical care setting would be optimizing drug therapy in terms of the different administration situations that we have in the ICU. So looking at dose adjustments for administration by NG tubes. We have adjustments with endotracheal tubes for our inhaler devices. We have adjustments for renal function when patients are on continuous or intermittent hemodialysis or renal replacement therapies. We also, when looking and reviewing at patients' medications, determining which medications need to be monitored for therapeutic drug levels and doing calculations and adjustments for that. We are always in our mind trying to minimize drug costs. So sometimes that's stepping down from IV to PO or deprescribing medications. We also have an active role in antibiotic stewardship in looking at antibiotics, duration, and spectrum of activity for what our patients are on and matching that with the microbiology of what's been growing. And of course, we do a lot of drug information with nurses and prescribers. We also do teaching with the new residents and the fellows when they join the critical care team for their blocks. And then I'll let Brianna kind of walk you through what that looks like in a typical day.
So a typical day for us usually involves at 9 a.m. we join the team and all the other interprofessional disciplines to go through handover rounds. So we usually get a report from whoever was on call and we attend those. And then as soon as those are done, we head right into bedside rounds with the team. So as Nikole mentioned, that's usually the physician, the residents, ourselves, and nursing. And this is where we kind of implement all the things that Megan had just talked about. So when discussing antibiotics, we will assist physicians with dosing, we'll assist them with durations. We may implement the therapeutic drug monitoring for drugs where we do have levels that have returned. And here's where we might also discuss home medications that the patients were on that are important for them to continue while they're here in hospital. So we do this for every single patient that is on our team. And then usually after rounds, we have a little bit of time to dive deeper into some of these patients. So this is when we might actually call the pharmacies to get a list of their home medications. We might interview family members to get a better idea of how they take their medications at home. We'll keep an eye out for those therapeutic drug levels that have returned in our information system. We will make sure that all patients' medications are teed up for transfer if they're heading out of the unit to a floor bed. We will make any sort of dose adjustments that have been identified after rounds. And usually that takes us probably till about the end of the day. And we do this for every single patient that's admitted here into the hospital.
Great. Thanks, guys. Derry, we'll hear from you next.
Right, thank you. I was just realizing, thanks to COVID, that's the first time I've seen Brianna's whole face, thanks to our universal masking policy. So anyway, so a little bit about respiratory therapy in the ICU. We really see all the patients in the ICU, but for the most part, our workload is focused on patients who have artificial airways, so endotracheal tubes or tracheostomies, and that are requiring some sort of respiratory support. In general, in the ICU, that support ends up being mechanical ventilation. So most of our job is really maintaining and monitoring patients who require mechanical ventilation and other respiratory support devices. And there's really always something to do, and it's a lot of work. There's something really always on the go. A big part of the coordination of our job is really with coming down to our time with the RN. And the RNs are really sort of the gatekeepers of the patients. And a lot of the times we're spending our day learning a little bit about the patients from the RNs. As Nikole had mentioned, in the mornings particularly, we're really getting a chance to sort of see who the nurse is looking after the patient, sort of see where things have been going and developing a plan. We do have a lot of routine work, but a lot of our time is spent responding to acute situations, emergency situations. It's sort of, I always sort of compare it akin to a firefighter or a paramedic. The RT's job is there is the routine work, but a lot of time we're just responding to situations that may or may not be necessarily acute, but you got to get there and assess that. And then we do spend a lot of time providing education to patients and family members, and our job is pretty specialized, and we do spend a lot of our time as well providing education to other team members as well. And that's, of course, employees and hospital employees and physicians, but also we do educate, other disciplines, students, so physio and pharmacy students, and we have a pretty big RT student program as well. A day in the life, a shift in the life of an RT, I guess. Starting in the daytime, there's 4 RTs, not including myself, that are in Kid 2 ICU, and they're dividing the workload up basically in about 3 in thirds. So 3 RTs are taking a third of the unit, and then we have a 4th RT that is really helping as an extra set of hands and covering for breaks and whatnot. And those RTs all have to collaborate together. I'm the Monday to Friday guy, so critical care is a 24-hour operation. So my job really is about coordinating and supervising and trying to provide some continuity. So our days really start in the morning. We have a quick huddle where the 4 RTs and myself will review all the patients that are in the unit. We kind of talk about the plan. And then the RTs start their rounds, and it's really just a perpetual set of rounds for the RTs. Every 4 hours, they're responsible for actually documenting a full ventilator monitoring. So that's when we first meet with the nurse and the patient. We do our full assessment, and looking at labs and chest X-rays and whatnot. Making changes to the ventilator. We do have a fair amount of autonomy when it comes to ventilator settings, choosing the settings, updating the physician on why we chose those settings and what we're responding to and what we're looking out for. every 4 hours they round 8, 12, and 8, 24 hours a day. The rest of the team comes around to do their bedside rounds sometime around 9:30 or so. Usually the RTs are still in the middle of their morning rounds. It's a tough time for the RTs to participate in those bedside rounds because they're still sort of going from bed to bed, providing active care. While the rest of the team is really reviewing things and coming up with a plan, we're sort of putting out those fires and catching up, circling back later on. The rest of our day is really spent planning things that we need to do, planning with the physicians and the nurses, procedures, tracheostomies, bronchoscopies, and every patient that needs to leave the unit for a test that's on a ventilator, an RT has to go with them as well. So it's a lot of collaboration there with the RN and all of those other, the CAT scan and the MRI to sort of set times and make sure everything, we have time to get everything done. So that's sort of it. I guess that's my bit.
Oh, that's great. Thanks, Derry. All right, I guess I'm up next. So I guess what does social work do in critical care? First of all, I just want to start off by saying, I don't know if you guys have ever been exposed to a social worker or not. I know in the community it's a big deal because most people think that we either are involved in child protection and take children, or we're in social services and we give money. So when you come to the hospital and you're involved in this kind of team, it's a really unique role as well, because we have a whole variety of different tasks and responsibilities that are not related with either of those things. And particularly in the critical care environment, it's quite unique. First of all, we tend to do psychosocial assessments, which essentially is an assessment with a patient and their family to look at their whole psychosocial situation. So what are all different aspects of their life, how they were functioning before this, what resources they have prior to coming into hospital, what concerns, what areas they still need to be connected with services for. The importance of doing this is essentially so that we have an idea where we're starting, because the idea when you come to the hospital, whether it's in critical care or anywhere else, is that discharge planning starts from the minute that patients come in. And so it might seem like a bit early when we've got patients on life support in ICU, but it certainly informs their family situation, some of the different challenges that we're going to be dealing with, as well as what's going to be needed down the road, because I also coordinate and liaise with my colleagues on the wards so that they have some of those details going forward. Partly for consistency of care, continuity of care, which is important in a big system like healthcare, and also just for ease of the families and patients so they don't have to retell their story over and over again. One of my key roles here, particularly in ICU, is being able to identify who a power of attorney, if a patient has a power of attorney, which is a legal document that designates a decision maker in the absence of the patient being able to speak for themselves, or a substitute decision maker in the absence of a legally identified power of attorney. And then sharing that with the team, helping to negotiate with families and helping them to understand sometimes why the decision maker will be who they will be, because they don't always understand that either. And sometimes simply even just tracking down family when patients come in with no one, not even identified sometimes. So it can be really interesting that way. I do a lot of orienting families to the intensive care unit. As you can imagine, most patients that come to ICU don't plan to come here. And so being that support person for families and helping them to understand how the unit works, what to expect, who's part of the team, and then giving them supportive counseling or even crisis intervention counseling throughout the time that their family member is in the intensive care unit. And practical resources, particularly either for the patient themselves. For example, if they're sick and they can't be at work, but they're worried about their bills and they need to apply for employment insurance or a disability, or the families themselves have to do those applications because they can't be at work because they're stressed and concerned and they're having to focus on their family member here. And they're terrified ultimately most of the time about whether or not their family member is going to actually survive. Helping them to understand even the language, and making sure that they are an involved part of the team. I really strongly push the idea of it being a partnership. And so helping families to know that and feel comfortable getting involved and knowing that they're very much a part of the team. I do tend to facilitate family meetings and try and manage expectations about when they'll see doctors, how quickly things change in ICU. These days in COVID, that has made it a lot more interesting and challenging because now we're doing meetings over teleconferencing. We've included people from all over the world in teleconferences so they can be updated on their family members, helping to manage expectations, why families can't be in the hospital at the moment with visitor restrictions, and why they aren't necessarily getting updates of change from the doctor themselves every day. That can be a real challenge for families because they're exhausted, they're frightened, and they don't really understand how things are going to go, and they want information. So that can be prove to be an interesting day. I can also identify concerns and conflicts. So if there's conflicts sometimes within families, sometimes between the teams and families, I'm just trying to work through the process of trying to bring people to the same understanding and finding different ways of alleviating some of that stress. I do a lot of grief counseling, and I talk a lot with families about whether or not their family member has an advanced care plan or an advanced directive. If they've expressed their wishes, do they even want to be in the intensive care unit? Have they ever talked about situations like this before? Or if we've made decisions or we have to talk about withdrawing life support and palliating patients. It's, as you can imagine, quite a sensitive topic. And so but I do spend a lot of time talking with people, and really from the perspective that we can do a lot of things to people, and we really want to make sure that we're doing what they want us to do. I liaise with the Trillium Gift of Life networks when there's organ donation cases going on, and with the ward social workers, as I said, and also outside agencies. Sometimes I can be the contact for service providers. Sometimes it's the police. Sometimes it's other healthcare workers in other hospitals when they're transferring patients. It's just a real variety. And then I'm really interested in the teaching and the evaluation of residents and students. So I've had social work students before. I've had nursing students do observerships. I've had medical students come in. I do some teaching with the fellows and the residents here within the ICU, and really mostly about communication, which is such a key aspect, in my opinion, of taking care of patients and their families coming through a critical care experience. So, and I guess that's just a few of the things, because I kind of joke all the time and say the other piece to my job is, the little statement at the bottom of a job description that says, "in any other duties," that you're not sure who to ask. So sometimes I can just be that person that will just go digging and try and find out information when we're not sure who to ask. And as far as a day in the life of, I can tell you, no 2 days are the same for me. I come in the morning and usually, check all my messages, try and get a sense who the patients are in the unit. Are there any hot button issues? Are there any messages that I've gotten I have to deal with before I go to the morning handover meeting with our larger team? I lead that meeting to coordinate just running the list of talking about any issues that have happened overnight from the residents who are taking care of the patients, and then any plans for today, or even the presentation of new patients, which gives myself and my colleagues all a bit of an idea as to what we're in for the day. Sometimes that can identify for me which families or which bedsides I have to go to first, which nurses I need to talk to, or which families need the most support initially. I am an automatic consult to every patient in ICU, but not every patient or family needs social work. So some are just an introduction to say, I'm here if you need me, and others I'm a lot more involved in. So I do a lot of introductions in the morning, researching different situations that may have happened overnight, or questions that have come up, or starting to search for families, or identifying powers of attorney. In the afternoons would be when I would tend to facilitate family meetings and case conferences. And that generally tends to take up the majority of my day. So it's always interesting. No 2 days are the same. But it's quite exciting, and I'm really quite blessed. We have a great team here. We work well together and really value the involvement of family, which is great. So on that note, I'll hand you over to the fabulous Al MacVicar, our physiotherapist extraordinaire.
Thanks, Cathy. Wow, you're a tough act to follow. What does a physiotherapist do in the ICU? What can a physiotherapist do in the ICU? Now, some of you may be hard-pressed to answer that question, unless, of course, you were looking at the slide. I wouldn't blame you for not completely knowing what our scope of practice is. A lot of my students, when they start with me, aren't familiar with the breadth and the scope of practice that a physiotherapist works in within the realm of the ICU. In fact, I've even had a physician in the past, obviously not ICU related, but once asked me, now what could a physiotherapist possibly do with an intubated and sedated patient? It was a very short conversation. We were on the elevator. Obviously, this was someone that really I felt wasn't very respectful of the profession. I wish he had a half an hour to spare and I could have informed him about what we typically do. As I've alluded to already, we have such a wide scope of duties and responsibilities. And I think the most important thing is that throughout it, you've got to be flexible. Cathy has touched on that quite a bit. And I never have 2 days that are exactly the same. For example, one of our primary roles, if you're looking at the slide, is that we are constantly assessing and progressing functional mobility of patients, to seeing how we can get them to be able to be more involved in their care, and how we can, even on a day-to-day basis, get them involved in functional activities, bed movements, transferring to chairs, walking, even stair training, that are going to be very important for them to go home. And believe it or not, we do have patients that actually do make it home from the ICU for several reasons. One is that sometimes there's just not a bed available. And we often have patients that are waiting 3, 4, 5 days, maybe longer, for a bed upstairs once they're deemed stable in the ICU. And secondly, that gives us an opportunity to work on them, get them stronger, and get them independent enough with their functional activities and mobilities that they can actually go home, and sometimes even without community services. So it's something that we take great pride in. I share my responsibilities with another physiotherapist, maybe Anderson, and we cover the 33 beds in the unit. But it's always amazing when this can actually happen. We also specialize in mobilizing complex patients with multiple comorbidities, which is something that we have to progress very cautiously with, and we can't do it on our own. For example, we might have a patient with numerous comorbidities that is also morbidly obese. And as you can imagine, there are many barriers to providing the care that is needed to get this patient strong enough so that we can get them eventually to, whether it's home or to their home hospital or to a rehab setting. And so that's something where a lot of planning has to go into place as far as the outline of your plan, the number of supports that are needed, equipment that is needed, and the type of intervention that is needed for this particular patient. Periodically, we will also provide chest physio and assist with optimizing respiratory function and secretion clearance. So we see a lot of patients, whether it's pneumonias or atelectasis, post-op patients, because it is a wide variety of patients that we do see, that we're able to utilize our chest physio techniques or manual techniques, whether it's manual percussions or expiratory bides or percussors. And it has to be patient specific, and not everyone obviously is appropriate for that based on their medical stability. Furthermore, we play a key role in optimizing strength, conditioning, and endurance of critically ill patients. And you can just imagine 1 day of bed rest for a healthy individual, you start to lose some muscle mass. So you can only imagine a patient that is intubated for a while or have been on bed rest, how weak they are when you eventually do get to try and progress them into a functional position, i.e. dangling or sitting up at the edge of the bed. And it's something that we don't take lightly. We have to do a very thorough screen that also begins with morning rounds and morning handover. And everyone that has spoken so far plays a key role in those handover rounds. In fact, I've worked with every one of the participants in this meeting with various patients over the years. And once you deem that a patient is medically stable and it's appropriate to perform an intervention, then you prepare your plan, and you get your people in place, your supports, and then from there, you're able to make a good decision on what you'd be providing for that particular patient. Now, if you look to the right of the screen, you see this particular patient. This photo was actually taken 2 weeks ago, and this is a perfect example of the collaboration that takes place here in the ICU. And again, I'm not putting that picture up there to pat myself on the back. It could have been any physiotherapist, but if you can see around me, we have an RT, we have an RT student, we have a nurse, we have obviously the patient that took the mask off for the photo, and his wife actually took the photo. And so in order to make this intervention happen, this is a young gentleman that came to us following a post-op surgical procedure on his abdomen. And we are trying to get him weaned down on his ventilator settings. And what better way to do that than to get him out of his room and to walk around the unit that we could really progress his functional strength and mobility. And for him, when he does this, it's such an uplifting experience for him to get the congratulations from a lot of the nurses that have cared for him. And it's just one of the highlights of my day when we can make it happen. But in order to make it happen, it usually takes about 30 to 45 minutes. And as Derry mentioned earlier, he's liaising with a number of the professions as well. And so in order to make this happen, we have to pick a specific time that works not only for the patient, he may be going for a procedure during the morning, but certainly for the RN schedule. And this is a gentleman that also receives wound care. And so there's a lot of moving parts there. And again, I come back to my point of being as flexible as possible and not working in a silo in order to make this happen. So for me, I find working in the ICU is very challenging. It's very stimulating. It is very challenging from both a mental and a physical perspective. Cathy, who has just spoken, and I often liaise with a number of our patients in order to best prepare them for their ultimate destination.
Yeah.
But from Dr. Bridge, who's also on the meeting here as well, it is a real team effort, very collaborative. There's a lot of communication and there's a lot of cooperation. And without it, patients just ultimately will not progress with their functional mobility. It allows me to do my job. Thank you for your time. Cathy, I'm going to pass it back to you.
Thanks, Al. That's great. Yes, you had quite the entourage with that gentleman the other day. It was great to see. So now we're going to talk to Kim. She's one of our registered dietitians in the unit. So Kim, over to you.
Thanks, Cathy. So I'm one of 2 dietitians in the intensive care unit. And what makes our role a little bit more unique is that I'm not only just in the intensive care unit, there's actually only 8 dietitians that cover the entire hospital. So I have 3 other units that I work for. And so my typical day is of course, screening those patients in the ICU, but also balancing that with the other units that I cover. So every ICU patient is assessed by the dietitian. We might not always see every single one of them because they might be more of a lower priority, but certainly anybody that is deemed to have a poor nutritional status, or we feel that they may be at some sort of nutritional risk during their ICU stay, we will be involved with them. So to do that, we use some validated screening tools. We may do a nutrition-focused physical exam where we're looking for muscle loss or fat loss, or looking at their hair and their nails, anything like that. We follow a matrix, so anybody that's a moderate or high risk will be seen. And of course, many of the ICU patients are malnourished, and this, of course, increases their mortality. Some of the patients need to be seen more frequently than others, depending on the complexity of the nutrition involvement. So once we've assessed them and we know that we need to see them, we need to form a nutrition care plan. And of course, most of our patients aren't actually able to eat real food. So trying to come up with a plan on how to do that. We're always looking at making different protocols on get the team started if they have a protocol on what to feed them and get them going, and then we can assess them and adapt that plan to what was going to be best for their outcome. And to do that, we follow evidence-based dietetic practice. We're reviewing current literature and different guidelines from different countries that are put out. We have to take into account the varying medical and surgical conditions that they may be going through. Maybe their gut isn't intact, or they're malabsorbing. Maybe their blood sugars are out of control. Maybe they have pancreatitis or food allergies, or different medications that are providing dextrose or lipid calories. We need to take that into account. Also, a lot of the patients, because they're so malnourished, they may develop something called refeeding syndrome. So trying to provide a plan for the team to make sure that we can try to avoid that as best possible, because it comes with a lot of metabolic issues. We need to prevent over and underfeeding with our plan, trying to come up with the best amount of calories and protein to be able to do that. But of course, most of our patients, like I said, they're not actually eating food. Most of them are fed through a feeding tube that goes in through their mouth, or maybe their nose into their stomach. Or sometimes we do need to feed them through IV bags or parenterally. And even if we are feeding them via feeding tube, we use formulas, but there's a slew of different formulas that have different compositions that we can adjust and add up to make sure that they're getting everything that they need. And then with the plan too, we need to make sure that we're telling the teams how much to give and when to give it, if it's continuous or intermittent or overnight or anything like that. And of course, we're collaborating with the team throughout this whole process. So when we're creating the plan, making sure with the doctors and the nurses that the patients are actually stable enough to have some sort of nutrition care plan. And then, of course, throughout their plan, throughout their ICU journey, to make sure that they're tolerating it. And if we need to troubleshoot any of those intolerances that they may be facing, if we need to adjust anything, we ought to make sure that that's not going to impact what other people are also doing. So, for example, if somebody's potassium's high and I want to adjust the solution to decrease how much potassium they're getting, I also got to check in with nephrology to make sure that they're not changing what they're doing, so that everyone's doing in their own little silo, making those changes. We got to try to avoid that. Same with like blood sugars. And of course, as reassessing the plan to make sure that it's maintaining or improving their nutritional status throughout their journey, and that's going to help optimize them, optimize their outcome. I'll collaborate with people like Al and the other physios to make sure that the plan is helping them with their mobility, checking in, making sure that they're weaning from the ventilator. I might collaborate with the RTs, especially Derry, to help me to do indirect calorimetry with the ventilators to have a more precise snapshot of how much calories the patient may be requiring if we feel they're hypermetabolic. And other collaboration to when they are ready to leave the unit, making sure that there is a dietitian to take over that nutrition care and help them progress back to an oral diet.
Great. Thanks so much, Kim. All right. And now to our fearless Dr. Bridge, Dr. Suzanne Bridge, to talk about the physician's role in ICU.
Thanks, Cathy. So as Cathy said, I'm an intensivist. This specialty as a whole tends to attract people who are very interested in being generalists still, so not picking an organ system, so to speak. We do see the sickest and most acute presentations of all the different disciplines, medical and surgical. And so what the people who tend to gravitate towards picking this particular discipline enjoy having to have a little bit of knowledge about everything. It attracts people who continue to like to do procedures and who like to work with their hands. We are constantly working with things like intubations or putting in big IVs into people, or doing procedures like bronchoscopy, diagnostic procedures such as bronchoscopy. And it also attracts people who are very much comfortable and enjoy dealing with acute illness and resuscitation. So people who are comfortable in that sphere. And those are the type of people who tend to gravitate towards working in this particular area. The roles that I consider to be part of an intensivist daily job include, but are not limited to. So on a daily basis, we're assessing patients for both admission to the ICU and the level of illness, as well as discharge from the ICU and liberation from critical care, as well as the life support mechanisms that we've employed during their stay. We develop daily assessments and plans in collaboration, with heavy collaboration from our interdisciplinary team in terms of how do we move the person forward through their critical illness, as well as with collaboration from the various disciplines. As I said, we remain kind of generalists, and we rely heavily on our consultant services to ensure that we are optimizing the care of the specific illness as well as the general critical care of patients who end up in the intensive care unit. Part of our role is coordination of care across the ICU as well as the hospital. So patients who are unwell in various locations of the hospital, be it the PACU or the post-anesthetic care unit, other critical places, emergency room, and other spaces, all have to be assessed for need for critical care, and with a balanced approach to the resources that we use. We provide regular phone consultations to outside centers who don't have the resources that our hospital does for consideration to transfer in. We provide support to our colleagues for patients who are severely unwell on the ward or in other physical locations who are not directly in the intensive care unit. So those are sort of general roles that we fulfill. To answer the question of a day in my life, so we tend to arrive in the ICU somewhere between 7 and 7:30. At that point, you get a list of the individuals who are going to be under your care for the day. Most of us try to do a walk around and see all of the people who are, it's usually about 10 or 11 patients who we are in charge of for that given day. Try to get a sense of anyone who's acutely unwell and needs things to happen right this moment, needs tests that are ordered, as well as events from overnight on patients who are more stable in that moment. And also get a sense for what the general plan needs to be for each individual person for the day by evaluating that sort of what's happened overnight and where we are piece. And that's all in preparation for 9 o'clock when we get together with the interdisciplinary team. We review, our job is to sort of present what we consider to be the overall care plan for the day, but we also utilize that moment to get some information from the interdisciplinary team, as well as to ask for help from the interdisciplinary team for people who we can readily identify are going to need some extra support, be it physiotherapy, nutrition, social work, and other things. Once we're done that collaborative meeting, we head off around 9:30, 10 o'clock, and we start going bedside, patient to patient around the ICU. And the morning is really about traveling to all of the patients within our care, and in collaboration with, again, all of the input from the team, deciding what the best course forward is for the day, ordering any tests that need to be done, arranging for any blood work, consulting any services or outside opinions that we need. We try to do that before noon. In the afternoon, we tend to spend our time focused on any procedures or meetings that need to be done for the patients under our care. And it's also we also spend a fair amount of time seeing new consultations and supporting outside of the ICU. And we do that all till about 4 o'clock when we prepare ourselves to hand over the care of the patients to an on-call night team who comes in from at least the medical side and will carry out any further tests that need to be done, follow up on any investigations that have been ordered through the day, and generally manage the patient overnight. So that's sort of what a day in my life looks like.
Great. Thanks, Suzanne. Before we go into kind of the next steps, I think we probably should have let everybody know as well. Our unique position here at KHSC is that we work in a 33-bed level 3 intensive care unit. It's actually a closed model, which means that our medical team, we have all of the different disciplines to manage the patients that come into intensive care. They're not managed by other specialty services like neurosurgery, general surgery, cardiac surgery, internal medicine. When they come into the ICU, Suzanne, Dr. Bridge would take over as the most responsible physician, and the critical care trained nurses and the other allied health staff would ultimately become responsible for that patient while they're in the intensive care unit, with other consultants coming in to give their specialty advice and direction on. We generally take care of patients that come from a very large area, I think spanning all the way from Oshawa to Cornwall and then up to the northern communities. So it's quite an interesting, diverse group that we get to take care of, and in a unique environment. So, and being that it's a closed unit, we have a really nice tight-knit team as well. So just so that you know that. The other thing to focus on here is that although we're all moving around the unit at different times throughout the day, we do tend to come together at different times to review either all the patients in the intensive care unit at like the ICU, the morning rounds, our team handover rounds, to review all the patients as you've heard people talk about. We also have ICU lunch rounds where some of our fellows and our attending staff will deliver education to the group. We've have case conferences when the multidisciplinary group will get together and talk about a specific patient and plans and challenges going forward, as well as family meetings, and then acute resuscitations. And surprisingly enough, they actually can include families. Just to let you know, we certainly take that into consideration here in the intensive care unit as well. So it may look a little different than you have thought of or been exposed to before, but we have a variety of people in those different situations where not only are we working throughout the day in the ICU, but really taking time to sit back and review things as a team together from every perspective. So on that note, I know I'm just trying to keep track of time here. And so we wanted to start with a bit of a case scenario for everybody. I'm going to throw these questions out to you as we go along. I will review the case of Mr. R that's been into the intensive care unit. It is fictional. And then I want you to think about the question at the end as we go along, because perhaps afterwards we'll have time for questions and answers. And you can give us some feedback on what you think maybe different disciplines would be thinking of as we go through the case. So we have a 50-year-old male who presented to the emergency room with sudden onset shortness of breath. He has a background history of COPD and multiple other medical conditions. He's working very hard to breathe and he can't catch his breath. This results in bringing him to the ICU for increased monitoring and respiratory support. So my question to you to consider at the very beginning of the case is to kind of pick a team member, jot down a few things that you might be wondering from their perspective, from the nurse's perspective, from the RT's perspective, from the physio's perspective, or any of us that have talked already, and what might be the to-do list, what might be your to-do list for this person, okay? So Mr. R comes to the intensive care unit. He's placed on BiPAP by the respiratory therapist, and initially he looks okay. He goes through the initial admission process, which also means that has different intravenous lines placed. He gets put on our monitors. He gets a head-to-toe assessment by the nursing staff and the physician, so they get a real handle on what's going on, and the RTs as well. And that usually takes about 45 minutes to an hour to get someone fully admitted to the intensive care unit. And then his family's allowed to come in and see him. So again, taking a moment to think about this from an interdisciplinary perspective, what things do you want to know at the initial admission of a patient when they first get to ICU? So the deterioration, unfortunately, this does happen. It's all too familiar to us. So despite being on BiPAP, Mr. R is still struggling to catch his breath. Given he has a history of bad COPD, he was unsure if he wanted to be intubated if BiPAP didn't work. But ultimately, after discussions with him and his family, the decision is made to proceed with intubation. As the team is getting set up to intubate him, Mr. R becomes bradycardic and has a cardiac arrest. He has a cardiac arrest in the ICU. What do you think your role would be? Pick a member of our team. What do you think your role would be in that moment when he has the cardiac arrest? And the blessed stabilization. So a cardiac arrest is run for about 5 minutes. The amazing team is able to get the patient, get him to have a pulse back. He's intubated and he's placed on life support. Mr. R's wife is updated by the medical team, and he is then currently heavily sedated and he's unconscious. How do each of the team members support the family during this time? Because things tend to hopefully slow down a bit during this phase of the patient's journey. and the illness. So he is diagnosed with a pneumonia. The team gives him, the doctor writes orders to give him antibiotics. Oh, sorry about that. There we go. Sorry. He develops renal failure, and then he requires dialysis. Every day the team rounds, as Dr. Bridge was explaining, and they develop a daily plan for Mr. R. What do you think they might be considering in that daily plan? Each different member of the team that's going and doing those rounds in the morning. And the recovery. Mr. R is sick for weeks. The team has trouble getting him off the ventilator. He's weak and deconditioned. A decision is made to proceed with a tracheostomy and a slower wean from the ventilator. Now we want you to consider yourself a team member. And what do you think becomes the consideration for people who have a more chronic illness? What do you think his family might be thinking? What do you think the patient himself would be thinking? And what do we as the team what might we as the team be thinking as well? So I'm going to hold there for a minute because I know that was a very quick read of that case scenario, but I wonder if any of my colleagues have anything to add to that before we go to the summary and then we throw it out for questions. Yes, Suzanne?
Hi, I might comment. So the goal of giving you those questions when we originally came up with them, the thought was that we could take you through all of the considerations of the discipline as we walked you through a patient with critical illness. But while we've been talking, a number of us have been texting behind the scenes and felt that we probably wouldn't be able to walk through all of our roles because it is in each of those moments. And so hopefully the case discussion allows the people who are watching to have an opportunity to think about questions or to inspire some questions about about what it's like to work in these individual roles, because literally for all of those moments in a patient's stay, we all have, every discipline that's sitting here today has a list of considerations that they would go through. And so the goal in doing that was really to hopefully inspire some questions. And if people don't have questions, I think we have the opportunity to go back and walk through the case in a little bit more detail, but thought we should pause there. Is that a fair summary, Cathy?
Absolutely. Perfect. Anybody else? Okay.
Cathy, I see a question, but I mean, it's not necessarily related to the case.
Yeah, that's okay.
The question says, fantastic presentation. I appreciate the overview of the challenges that each profession faces from their perspective and also what they enjoy about working in critical care. I wondered if you could speak to how you manage the emotional and/or spiritual challenges that you witness in providing care.
Well, that's a really big question. And I guess my question there would be, maybe we can throw it out to, do they want to ask any particular person on the team about that, or we can speak to that in general?
I think so. The way I read it, it's more in general. How do you?
Okay. Well, I mean, maybe I'll start and then I can get the rest of my team here to chip in. What I would say is it's unfortunate we didn't have someone from spiritual care here, because we do have someone on the team in the hospital from spiritual care who is another member of our interdisciplinary team. But for ourselves, we do a lot to support one another. I think, as I said, we're a pretty unique group in that we have a closed model here. So we kind of get to know each other pretty well, and we can be pretty mindful of times when some particular cases or situations are more emotionally challenging for some. We all have times when they touch closer to home. And so I think maybe checking in with one another, even checking in with yourself and being mindful. Self-awareness is really important, and giving yourself permission to acknowledge that you need to take a little break. Maybe you need to go for a walk. Maybe you have to have a good cry, find a private space somewhere. Talk openly with colleagues to kind of debrief as well. And we also do have debriefing sessions from time to time when there have been particularly upsetting cases that have come through the intensive care unit. And I think as much as we tend to go through every day, probably looking pretty unshaken, I guess, most of the time, I think we also want to be mindful that we want to make sure that it does touch us to a certain extent, because if it never did, then we'd probably question why we were here in the first place. But I can only speak for myself in saying that, yes, there's lots of sadness, but there's actually surprisingly a lot of resilience and strength, both within the team members that I've had the privilege to work with, but also with the families that we see and the patients that we work with. There's incredible stories that we get to bear witness to. And for me personally, that gets me through. You guys speak to anybody there? I'll speak to that.
I can sort of speak to that too. Like, we definitely see some really intense situations, really sad situations. I would say for me personally, one of the more challenging things isn't seeing people pass away. It's almost more so when people are kept alive for too long, I would say, is maybe one of the more, like, it's more morally distressing. And that could be, you know, for various reasons, because, you know, that's what the family wanted to do, or because we're just trying different things. And so that can sometimes be really distressing. And I think talking about it with your coworkers is a really good way to sort of decompress, because they really understand sort of the situation and what might be morally distressing to you. And I also think a really good way is to have outlets like outside of work, like finding something that you're passionate about, something that you can focus on, sort of outside of work that gives you joy, and that you can do to sort of alleviate some of that stress, and really just talking about it and decompressing after a really, you know, traumatic event, and going over things. And because sometimes you always wonder, you know, could I have done more? I think everybody sort of questions that at some point in time, and so debriefing after a really critical event can be very helpful.
I'd like to add that you're seeing my name light up because Nikole, our nurse, is using my microphone. So you are getting our nursing perspective, not just my incredible ability to talk without moving my lips.
I got something I could add to that. I find there's a lot of very sort of complex tasks that we need to accomplish in the course of a day, and I think focusing on those tasks is something that I do. So, you know, you end up having a kind of a narrow focus, and you're accomplishing what needs to be accomplished now, and when that thing is done, you're going to move on to the next thing. And that really sort of keeps you just propelling you forward through the day. You're getting the things done that need to get done, knowing they're all for this greater good. And myself personally, as far as decompressing, my wife is a nurse, and I'm pretty sure if I couldn't come home and just sort of go through, I'm sure if she worked somewhere else, it would be a little different, and she wouldn't want to hear the things I have to say about how my day went. But that's very helpful for me too.
Anybody else on the team? Oh, Al, we got to unmute you. There we go.
Sorry, can you hear me?
Yep.
Yep. If I could just add a few things as well. I think I'm in a unique position where there's consistency, where I'm pretty much the same physio in a certain area of the ICU day in and day out. So a lot of the family members get to know me, whereas they get to know all the nurses as well, of course, but oftentimes they won't have the same assignment on consecutive days. And for me, I'm just so impressed with the emotional resilience that we see from these family members day in and day out. And obviously with restrictions, it's so much tougher for them these days. But I think I take strength from their courage that they consistently display in the face of really tough times, especially with some of the younger patients that we've had. We've seemed to have a lot of them in the last year or so. And I think the fact that they're so gracious of everything that you can do. And I think family members just want to know that you're committed. When you are there, you're not necessarily going to fix everything, but they want to make sure that you are totally all in and you're engaged. And if you can demonstrate that, I think that you'll only have their support, and that they know that you're looking out for their loved one. And we all had loved ones in the hospital and ICU for that matter. And we can relate to that. We have that empathy because we can only imagine in some ways, or we can relate it to a specific situation that we ourselves have had. So it is good in the sense that we have each other to lean on. That's been mentioned. And I think, again, it's the feedback and the support that we get from family members that helps us through. And then when they're able to come back in the future and visit us and give us those success stories, is so worthwhile. Cathy, you and I have been involved in a number of those stories recently, which is very fulfilling. But again, from a personal perspective, that's what really helps me. Thanks, Cathy.
Thanks, Al. Anybody else on the team? Okay. Well, I guess one thing that maybe got left out too is a sense of humor is a terrible thing to waste. And although we work in a tough place, at the same time, there's lots of reasons to have a laugh and lots of reasons to share in those times as well. And that can really help me. But we have an incredible team. And I think at the end of the day, it's the support that you get from your team and feeling confident and working together, or even families, whether their family members survive or not. At the end of the day, it's pretty nice to hear families say, you know what, thank you for what you did for my family member. And it happens more than you would think. And Al raised a good point. We do have times, not COVID times, mind you, because right now we're in a bit of a challenging situation, but we have usually 4 times a year, we will have a patient and or their family come back to the ICU to give us feedback and to tell us about their journey and what they remember and how they felt and what we did well and what we could work on, which really can actually be quite inspiring as well. Any other questions, guys?
Cathy, maybe if people want to unmute themselves, they can do that as well. I know some prefer.
Yeah.
Some prefer to just ask the question directly rather than type. So that now would be a good time.
All right. Unmute away. I don't hear any questions coming up out there just yet. And if you haven't gotten this sense already, I'm a bit of a talker, but I do like silence as well, but for a little bit. I really do hope, guys, that we've given you a bit of a sense as to what the individual roles of each of our positions brings to the table in critical care and how our team comes together for patients in our setting. I wonder, just as one final thought before the end of the session today, I wonder if maybe each of the team members, we could go through you guys and maybe you could tell the group, like maybe one of your favorite things about your job, what about your position, just to share. Maybe we can end it on a positive note. Maybe we'll start with you, Suzanne.
Sure, no problem. That's a hard thing to put down to just one. But I will start by saying, and not just because of the rounds that we're giving, my favorite part of working in the critical care unit has really, aside from kind of the intellectual stimulation and the rewards of what I do personally, has actually really truly always been being involved in a team. I love having the opportunity to make sure that I maintain a really global perspective about people and their health. And I think that working within the team forces you to do that and really adds to my ability to do a good job that I can feel good about, because I never get stuck just in my own head. You have always got this team of people around you. So I think that can't be underestimated. And I've worked also in the community where ICU can be a little bit more isolated and we don't have the kinds of resources that we've been lucky to have at Kingston Health Sciences. And it's a real big difference in how much joy I derive out of my day-to-day work, having the types of interactions we have the opportunity to have and being surrounded by the type of expertise that I'm surrounded with on a daily basis.
Thanks. Derry, what about you?
I think one thing I'd like to say is I'm just realizing now how little we actually talk about being a team. We all do our roles and we do a great job, and we practice being a team in certain scenarios like Code Blues and certain things where we're physically practicing working as a team. But just to realize, hearing everybody talk now, how everybody just sort of does their thing and it's all for the greater good. And I'm more impressed with us now after this talk than I was when we started. But I'd say for me, the things that I get a joy out of is I have a pretty specialized role, and I get a lot of enjoyment out of being able to share that knowledge and to be the one sort of looked to manage the very specific thing, which is generally the ventilator in the ICU. And I think probably the most feel good part of my job is actually getting patients home. It wasn't very long ago, well, 10 years, maybe that's a long time ago, but we never sent patients home from the ICU before. And things have changed, and we've gotten better at a lot of things, and the technology's changed. And getting that patient, this case study that we just talked about could be a real patient. Very difficult times, very difficult stay. Doesn't look like things are ever going to get better. And then, sometimes we turn the corner, and then getting that patient ready to actually go home, and maybe they're going home on a BiPAP machine or on a ventilator, and their lives has significantly changed, but they still have a life, and they're grateful for it, and they're grateful for everything that we've been able to do. So actually doing all that training and all the planning that is required to get a patient with some respiratory devices out of the ICU, and seeing it be a success, that's probably my favorite part of the job.
Great, thanks. Al.
Oh, I was just gonna, sorry, I didn't want to
Nikole?
interrupt there. I saw another question that might be pertaining to nursing there.
Yeah, no, jump in, Nikole, great.
Yeah, someone just asked, what recommendations do I have for a new grad or a nursing student wishing to enter the critical care setting? I would say a couple things. I would say my biggest piece of advice, and it was something that I gave to my nursing student as well, is to do floor nursing first. Go to the floor and get your foundation, get your time management skills, get better at recognizing when you have a deteriorating patient, and sort of get that groundwork. It doesn't have to be for a long time. I only worked on the floor for 1.5 years, but it really lays that foundation. I was a student we have a critical care float position that floats to a lot of critical care areas in the hospital, and I absolutely loved it, and I knew I wanted to work in ICU. But my preceptor gave me some advice and said, go to the floor first. And I think it was a really, really great piece of advice. The other thing I would suggest too is to do a critical care course. Some facilities make it mandatory, but Kingston does not, but it's something that I took the course, and I found that really helpful as well, just to sort of consolidate your knowledge, because there's a lot of extra pieces, especially for nursing in critical care. Just the equipment alone is a lot different than the floor. So I would really recommend doing that as well.
Great. And your favorite part of your job there, Nikole?
Yes, my favorite part. So I have so many favorite parts of my job. So like a lot of people have mentioned, I really like the team aspect. And I really like how the physicians and everyone here is so great at teaching. You have a question, they will sit down with you and answer your questions. And I really, really like that, because I feel like you should be learning something new every day at your job. And it's really great. We have a great staff, and I really like nursing in general, because, like I was saying about being an intensivist, you know a little bit about a lot. We sort of look at all the systems in nursing, and we're sort of I think Derry said maybe that we're the gatekeepers to the patient. We're sort of the in-between person. And I really like working with the families too. They're so appreciative of everything that you do. And I really enjoy that as well. I just like helping people.
Thanks.
Hi.
Al.
Sorry.
Oh, no, go ahead. Question?
Sorry. I have a quick follow-up question. I was going to ask the one about nursing.
Absolutely.
Yeah.
For you saying floors, are there any specific floors you would recommend? Is that just med-surg floors, or
Yeah, med-surg. No, I can definitely answer that quickly. Med-surg is great. I find medicine, it can be a bit daunting because the floors can be heavy in terms of workload. But I find medicine could really prepare you well for critical care, just because everybody has so many comorbidities and people can deteriorate really quickly. That being said, a surgical floor is also very interesting as well. You get to see all sorts of surgical cases, and patients there can deteriorate rapidly as well and have all sorts of complications from surgery. I worked on a floor that had both, so I got really lucky. But I think both areas, if I had to suggest one, I would maybe suggest medicine over surgical.
Thank you.
Great.
You're welcome.
Any other questions out there before we go on to Al? Okay. Al, you're up next. Favorite thing, bud?
Thanks, Cathy. And for what it's worth, Nikole, I think you're an excellent gatekeeper. I would have to agree with Dr. Bridge that I love the supportive network that we work in. And I too have come from the community. I did a number of years in the community, about 14 years or so. And the fact that I feel that there's always a little bit, for lack of a better term, a safety net. And I feel that physio is very well respected in the ICU. And I think people are very accessible. And I can easily go and talk to anybody if that's a difficult decision that I have to make in regards to formulating a treatment plan. I'd also have to agree with Derry. I love getting patients home. So sorry, I have a couple of things here that I really enjoy, so I'm going to list them all. But I absolutely love working through the process and getting patients on to their ultimate goal of going home. And again, I guess lastly, working with a really complex patient. I think some of us may remember we had a polytrauma patient, former athlete that came in a year and a half ago. And at one point, it was a very grim prognosis, and we weren't really sure what was looming ahead for this poor individual, perhaps that he may not walk again. And to see him go from this intubated, sedated, highly sedated stage to engaging in functional exercise at the side of the bed, to eventually getting well enough to not only leave the unit, but to go to a rehab unit and to ultimately be discharged home and to be doing well in the community to this day, is just very rewarding. And I think we can understand and appreciate all of those cases. That's all I have. Back to you, Cathy.
Thanks, Al. Brianna, what about you?
So I would pretty much echo almost everything that everybody has said so far. Me being a resident just about a year and a half ago, I came into the ICU and I feel like every single profession welcomed me even as a learner in this environment, which was great. And being able to continue to practice here afterwards has been very rewarding. And I love the team environment that Dr. Bridge kind of alluded to. But pharmacy specific, I find that sometimes we see the most sick patients, and that often gives us time or an opportunity to use a new drug that I've never used before, never heard of, that some of these consult services are recommending. And I find it really rewarding to be able to educate myself about that drug, but to also see the family members and the patient really benefit from those therapies, and to see how happy they are that their family member is making progress due to drug therapy. So that's something pharmacy specific.
Great, thanks. And Megan.
So the two main reasons, they've been touched on before, but mostly the learning environment. And after working for 8 years, I'm still learning new things every week about different disease states and different things that are going on in the ICU. So I love that, continuously learning about things. And then, of course, the team environment. So when the pandemic started and a lot of my cousins and friends hadn't seen people for days and weeks and months at a time. And I kept thinking, wow, I'm so lucky that I work with a team of people in the ICU that I get to see and work with every day. And it is a great feeling to be able to support each other and have that social aspect as well.
Awesome. Thanks, Megan. And Kim?
For me, I would also echo what a lot of other people are saying about the learning and being with a really supportive team. You're never on your own. For me, I knew that I wanted to work in critical care since I was a student at the Ottawa Hospital. Whenever I would go into their ICU and as a casual and cover there, that's where I wanted to be. But then coming here, of course, when there's only 8 dietitians, it took a long time to get into the unit. But that's also a blessing because I covered so many different areas that I can use all those tools and skills and apply them every day to the different patients that I see. And it's also a lot of math, and I'm kind of nerdy like that. So you always can find the dietitian. They've got the calculator.
Oh, thanks, Kim. That's great. And I guess I have to share my one favorite thing. Of course, apart from the fantastic team, I came to this hospital 13 years ago and knew I wanted to be in critical care as well. And after 1 year, surprisingly, I was here in the intensive care unit, and I have really enjoyed it ever since. The team's great. And the one thing that I would say that kind of keeps me going and that is really special is that families will say, how do you do this all the time? And I always say, you know what? If I can make maybe the worst experience of your life even a little bit easier, then that's my day. That's exactly why I'm here. And that's what brings me the satisfaction. And if it happened to me and I was in that position, I would want someone to do it for me. And I think we're blessed in having a team that's all very committed to patient and family well-being, which is fantastic. And I really, on that note, want to say thanks so much for your attention today, guys, and your participation. I hope that we get to see you in our unit and you get to experience us in action for yourselves and maybe even become part of our teams. And I wish you lots of luck and lots of great learning out there, because it's an ongoing journey. But thanks for your attention and your time.
Thank you so very much on behalf of everyone on this call, not just for sharing your expertise and knowledge and the wonderful case, but also for actually getting us to watch how you work in action. I mean, we can sense from everything that you said how special this team is. So thank you. Thank you so much for sharing that with us. And there are many thanks as well on the chat. With your permission, maybe we can share the recording with the students who couldn't be here today. Excellent. That's wonderful. Well, thank you again. We're so grateful. Have a wonderful evening.
You too, everybody. Bye.
Bye.